anticoagulation here with the group at the Mount Sinai in New York. So it's a pleasure to have Dr. Deepa here today talking to us about navigating cancer-related thrombosis in the DOAC area. Thanks, Deepa.
Good morning, everyone. Thanks for that introduction, Carlos. Are you guys able to see the screen?
Yes, perfect.
Okay, perfect. So it's a great pleasure to talk to you guys. I know it's going to be a bit of a shift from all the cardiology talks, but I think it's relevant. Today, we are all going to put on our internist hat because I'm pretty sure you will come across these patients in your clinical practice. And the evidence in this area is changing so rapidly. So I think it'll make for an interesting discussion. So without further ado, let me just start. So the objectives of my talk is going to be mainly to briefly review the burden and impact of VTE in cancer patients. We will talk a bit about discussing factors that influence the treatment decisions for patients with cancer-associated thrombosis. For the rest of the talk, it will be called as CAT. Review the latest evidence for efficacy and safety of the direct oral anticoagulants in the management of cancer-associated thrombosis.
Yep.
We'll talk and discuss some of the recent guidelines on CAT and how they can be applied to the Canadian healthcare. It's interesting when you look back at the cancer thrombosis and a historical review, and I'm a bit of a history buff myself. So it's fascinating to see how the medicine has evolved over the course of time. So this association was first established and thought to have been observed back in the 18th century, when a French physician described the association between VT and cancer back in 1823. You guys all must be very familiar with Armand Trousseau. He was the one who reported the association between gastric cancer and VTE in 1865. Interesting story is that ironically, he diagnosed himself with the DVT and later on died with gastric carcinoma. And then came the bigger establishment of, whether there is a close interrelation between metastasis formation and activation of the hemostatic system, which was established by the Theodore Billroth back in 1878. So certainly we have come a long, long way since then in management and understanding of the cancer thrombosis. When you look back at the epidemiology, certainly we are all aware that the cancer is a very strong and independent risk factor for VTE. Accounts for 20% of all the VTE, and risk of cancer overall in cancer patients is increased from 4 to 7-fold. It's not a surprise given that high risk that it causes significant mortality and morbidity in cancer patients and remains a second leading cause of death in cancer next to cancer progression in itself. The high recurrence rate. Cancer patients in general are a very complicated bunch. They also are at high risk for recurrence of VTE within the cancer despite being sometimes on therapeutic anticoagulation. They are also at higher risk for major bleeding. It's always a balancing act, more so in the cancer patient compared to the non-cancer, to achieve that perfect balance of managing their VT risk along with their bleeding risk. The sequelae of the cancer thrombosis, now we understand, is not just limited to physical, but can also confer significant psychological burden on patients. I do run the cancer thrombosis clinic here at Calgary, and I have seen this majorly on the first-hand basis, how much it impacts them psychologically. Because you can imagine, as a cancer patient, putting yourself in their shoes, they're already dealing with the bigger issue of cancer, chemotherapy, making their lifestyle changes, and now there is an added risk of dealing with blood thinners because of a blood clot, which potentially can kill them. So this is just a study by Cohen et al. From UK looking at the incidence rate of first VTE in patients with active cancer. And that's reported at as high as 5.8 per 100 person years. And you can see between the genders of male and female, and most often in the younger age group, it's usual male predominance, but over the age of 50 to 59, there is certainly higher female patients with similar kind of a risk as a male of developing first-time VTE in cancer. Why is this important? Again, cancer-related VTE carries significant high risk of mortality rate. And this is one of the studies published by Tim JF, which looked at what was the risk of VTE-related mortality rate if they had in the setting of cancer. And as you can see, if they had cancer-related VTE, that risk is much, much higher. Living in a public healthcare system, we are also have to balance this out with healthcare costs, and these are not negligible. Cancer patients with VTE initiating chemotherapy, this are also causing significant healthcare burden. And this was a study published by Corona et al., looking at the outcomes and comparing the healthcare costs between cancer patients with VTE initiating chemotherapy, comparing them to a cohort of propensity matched cancer patients without VTE. And you can see from this graph that the cancer patients with VTE have 3 times increased all-cause hospitalizations as well as days in the hospital. Total healthcare costs generally are 60 to 80% higher in cancer-associated thrombosis patients. The similar kind of a thing has been observed even when they suffer with the recurrent VTE. Remember, they are also at high risk for VTE. So patients with recurrent VTE also had higher all-cause and VTE-related health resource cost compared to those without any recurrence of VTE. Total VTE-related healthcare costs were significantly higher among patients with recurrent VTE compared to those without recurrence. And this was mainly because they have more hospitalizations, more healthcare needs, more significant prolonged hospital stay. When it comes to assessing thrombotic risks in cancer, we are all aware of this Worker's triad, which talks about the 3 overlapping factors here, which is due to stasis, vessel wall injury, hypercoagulability, creating the perfect storm for the clot formation. There has been certain predictive models to help us assess that risk of VT, and the popular one that is used is the Corona risk score, which again assigns risk score depending upon where the cancer is situated and what's the pre-chemotherapy platelet count, hemoglobin count, and their BMI, and gives you a risk score. And anything above 2 or higher is considered as intermediate to high risk Corona score. That means high risk for VTE. Then there is other related risk factors, which could be patient related individually, treatment related, because these patients are also on significant amount of other agents like hormonal therapies, anti-angiogenesis agents, chemotherapy. They will be undergoing surgeries. They will need transfusions, indwelling venous access. All of them will increase their risk of VTE generally. And then there is, of course, age-related risk factors, ethnicity, comorbidities, which we are very well familiar in the non-cancer population, which is similar in the cancer patients as well. So as you can see, it's not a surprise that these patients are at such significant high risk for developing blood clots. Cancer-associated risk will vary based on the tumor types. So when you look at it, which other thrombogenic cancers, it's certainly the GI malignancies such as the pancreas. And then there is followed by a whole slot of stomach cancers, the uterine cancers, lung cancers. But when you look at basically the incidence of it, with the exception of lung cancer, the most prevalent cancers, and thus these are the ones that represent most of the cancer-associated thrombosis population in clinical practice and clinical trials, but they are not the most thrombogenic cancers. You will see overwhelmingly breast, prostate, lung cancers represented in the randomized clinical trials. So something to take into considerations that even though we do the most prevalent cancers are the ones which drive, which are represented in your randomized clinical trials, but those are not the most thrombogenic ones. This is a graph I always show my residents and fellows because it's important to understand that the risk of thrombosis shifts throughout a patient's cancer journey and it never remains the same. Overall, when you look at this graph, it's beautiful representation. How high is that risk? If you look at the baseline risk here, and this is the risk of VTE in general population, you can certainly appreciate that the risk of VTE in cancer population is that much higher. And within that range, depending on where the patient presents at his cancer journey, certainly there are certain times when there is even higher risk than that risk of VTE in general. Like at the time of diagnosis, you can imagine they're undergoing biopsies, they would be needing hospitalizations for indwelling venous catheter insertions, surgeries, and initiation of chemotherapy, all of which would definitely increase the risk of VTE at that point of time. Then let's say that they have had reasonable control of their disease. But even when you look at this, you can certainly appreciate that the risk of VTE never really goes back to the baseline risk in the general population and always remains high enough. And then as the disease progresses, that they move into the metastatic phase of cancer and end of life, you can see that the VT risk never really goes down. In fact, it keeps going higher up as they move towards a palliation and end of life. And that's where it doesn't surprise us that like the VTE remains a second leading cause of death in these patients. The reason why this graph is important to understand is that it's never been one size fits all in the management of VTE. There is no single drug that possibly would you would prescribe to the patient throughout their cancer journey, because you will need to adjust it based on where they are at in that cancer journey. And this is where possibly the newer introduction of direct oral anticoagulant agents are going to make a difference, that you tailor them based on as the patient moves through this the whole cancer journey, depending where he ends up. So now that we know that there is a high risk for VTE, can we not prevent them by prophylaxing them early on in their cancer journey? And this certainly has been assessed in multitude of studies. I'm just going to touch upon the two major studies, which was mainly in low molecular weight heparin, that is predating the DOAC's trials. So the the two major ones that we're going to touch briefly about is the PROTECT trial. And this was in patients who were newly diagnosed with cancer, initiating chemotherapy. And these were all ambulatory cancer patients, not hospitalized cancer patients. And they were randomized to receive prophylactic nadroparin, 3,800 unit. This is a form of low molecular weight heparin, at a prophylactic dose or to the placebo. And they were followed for a median of 3.5 months. And among them, as you can see, they were differences in terms of the patients who were in nadroparin arm versus placebo, that the nadroparin arm patients developed VT at 2% compared to 3.9% on the placebo arm. Similar kind of a thing was seen in SAVE ONCO trial, which also stratified VTE by cancer type, stage, and baseline risks. But none of these investigators or trials used a risk assessment tool like a Corona risk score for enrollment. And SAVE ONCO showed a similar kind of a story with semiloparin, which is another low molecular weight heparin, that there was lower rates of cumulative probabilities of VTE with semiloparin compared to placebo. Why didn't this change practice? This really didn't change a lot of the clinical practice, because it was a low magnitude of VTE reduction, and overall it was a low benefit risk profile, and hence this was not widely adopted as a standard of care in cancer patients for prevention. Things have shifted a bit since then, with the direct oral anticoagulant agents coming into this foray. Certainly, we are all well aware of the robust evidence supporting direct oral anticoagulant for the treatment of VTE in non-cancer patients. And this was recently published two studies, which was looking specifically at a prophylactic dose of direct oral anticoagulants as a means of reducing occurrence of first-time VTE in these cancer patients. They were a bit different in their patient population. The other trial was by Dr. Mark Carrier from Ottawa, and this looked at Apixaban 2.5 milligram twice a day versus placebo, whereas the Cassini trial evaluated similar patient population and randomizing them to rivaroxaban 10 milligrams daily versus placebo. Both studies required a corona risk score of greater than 2. Focusing on our trial in itself, the interesting part of it was it had increased rate of lymphomas and gynae cancers, whereas Cassini had your more common thrombogenic pancreatic and gastric cancers. Cassini also excluded patients with asymptomatic VTE and had a relatively very stringent inclusion criteria. But you can argue that that did reflect a real world population because they used, interestingly, screening bilateral leg ultrasound at enrollment with occlusion of 4.5% with incidental proximal DVT. Because this is not really routinely done in our practice, that we do routine screening bilateral ultrasounds in these patients. So that's the part about Cassini. But overall, AVERT had a statistically significant difference, as you can see, in primary outcome in reducing the VTE risk with the modified intention to treat analysis. Notably, there was a significant reduction in VTE in the pre-specified treated population in Cassini. Both of them had high discontinuation rates, up to 37% in AVERT and 47%, and nearly 40% of the events in Cassini were in patients after treatment discontinuation. So there we have some data for AVERT in the form of low-dose Apixaban and low-dose rivaroxaban. Again, I always tell that you look at the exclusion criteria when you're trying to apply this to your patient population, because depending on the type of cancer that we are dealing with, these would be important whether we are extrapolating the data from these patient population to the one whom you're seeing in your clinic. So what about bleeding? Because that's a big factor, right? So we are reducing risk of VTE, but what about bleeding? And noticeably, certainly they had higher bleeding rates with low-dose Apixaban as well as with low-dose rivaroxaban compared to placebo. And again, this should come as no surprise, as we did allude that the cancer patients are generally at a higher risk for bleeding compared to non-cancer patients with VTE. And those bleeding were mainly in GI, hematuria, gynae bleeding in patients with those malignancies. This is a very good baseline characteristic comparison for primary prophylaxis of trials in cancer by my good friend and co-thrombosis researcher in Edmonton, Dr. Cynthia Wu. And this outlines basically, all the differences between the trials put side by side. So as you can see that, there was corona risk score assessment was not done in the previous trials, but we did do that in the recent trials with the DOAC. And it gives you a certain understanding about the types of cancers. Again, this I'm putting it out there for the thrombosis nerds like myself, and if they want to dig in a bit more deeper into these trials. Overall, what's the verdict on this? So are we doing primary prophylaxis or not? So there is certainly an emerging data on DOAC supporting their role for prevention. But you have to understand that there's significant heterogeneity between the studies, and there has been low absolute event rates with the older studies with the low molecular weight heparin. The newer guidelines now, based on the recent DOAC trials, have incorporated this option of prophylaxing them, especially in the ambulatory at-risk patients, possibly with the DOAC. However, cost effectiveness, drug coverage plans remain an ongoing concern because we are unable to get them coverage for the low dose Apixaban and Rivaroxaban for the prophylactic aspect in cancer prevention. Certainly in Alberta, it's a challenge, and I know for sure that in the other provinces, this is an ongoing issue as well. Then comes the issue of duration. So when we do start them on prophylaxis, then how long do we need to keep them? Ideally, you should be keeping them throughout their until their cancer is deemed to be in remission. So there are other concerns about is that feasible to do so? Um, so overall promising results, but I guess we will still not yet widely accepted yet, mainly due to the cost effectiveness, cost concerns, and drug coverage, which remains still an issue for us. Before next, we will move on to tailoring medications to individual cats. So how do we pick and choose? When we have more options, it's certainly more challenging. Which one do we choose for, and to which patient? And then remember, we don't have great tools for assessing bleeding risk in cancer patients. We don't really have any validated scoring system that has been developed specifically in cancer patient. We do have in atrial fibrillation population has blood stool, which is sometimes often used, but never been validated in the specifically in the cancer population. And we all know cancer itself is a major risk factor for bleeding. So in fact, major bleeding in cancer randomized trials have reported at around 4 to 7% risk in that 6 to 12 months. And in addition to that, there are other cancer specific risk factors depending on its luminal tumor, extraluminal tumor, are they on antiplatelet agent, concomitantly, what's their renal clearance, etc. And then there are generic risk factors for bleeding, including age, comorbidities, etc. So this was assessed as a pre-specified bleeding risk factors. Some of them were looked into in the Hawkes IVT cancer study, which compared edoxaban to Deltaparen in the cancer VTE patients. And they looked at few of the things like surgery within 2 weeks, use of antiplatelet therapies, did they have a primary or a metastatic brain tumors, was it regionally advanced, what GI-GU tumors, and then bevacizumab, which is known to increase risk for bleeding. So they did confirm that, that these type of cancers, certainly if they have a lower creatinine clearance, if they had a low platelet count, use of concomitant antiplatelet agent certainly increase the risk. So if they had 3 risk factors or 4 risk factors or more, and certainly if they had 3 risk factors or more, that was statistically significant, higher risk for bleeding compared to the patients that did not have that, and especially that was seen with DOACs when compared to Deltaparen. Again, some things to consider. This was another population-based data from 26 major healthcare systems spread across US. Close to around 3 million patients who received variety of anticoagulants, warfarin, rivaroxaban, low molecular weight, and Apixaban, looking at bleeding incidence and the factors that influence. So as you can see, having these other risk factors like chronic kidney dysfunction, metastatic disease, luminal GI tumors, platelets, all of them would increase the risk for bleeding compared to the other cancers as well. What about drug-drug interaction? Still remains an ongoing concern, and certainly even in the non-cancer world, we need to be cognizant about the drug interactions with the direct oral anticoagulant agent, especially given their part with the CYP3A4 pathways and the PGP. And this gets even more complicated when you bring in the cancer therapy. So as you can see, it is quite challenging when you look at the drug-drug interactions because there are many in anti-cancer agents, and even the ones that are used for supportive therapy like dexamethasone, the steroids, and the methadone, fentanyls, aprepitant, the anti-nausea medications, all of them can have potentially drug interactions with the direct oral anticoagulant agent. So to tailor them, even though we have some data for DOACs, would need to take all these factors into consideration when deciding which drug is appropriate for your patient. But what does the patient want really? In general, the patients prefer that anything that won't interfere with their cancer treatment, and that's a significant important to them. Certainly, they have to be efficacious, and they also are worried about risk of major bleeding and overall. So the frequency of administration, like if you tell the patient that they have an option of going on the needles versus an oral pill, certainly that's an attractive option to go on an oral pill. But remember, when you look at this study by Noble, uh, um, did show that that's one of the relative important that not the main important for the patient. The main important point is that it should not interfere with the cancer patient. It should be an efficacious treatment. So making the right treatment choice, given all these options of CAT, what do we need to understand? That these are very heterogeneous. You often have to tailor this therapy based on individual risk factors, such as bleeding risk factors, what's their significant clot burden, what's the type of cancer, and of course, patient preference is certainly key. And just remember that the risk of cancer varies throughout the cancer journey. So there likely is not going to be one size fits all, and you may need to alternate in your anticoagulant therapy. Maybe they start on a DOAC, then you move on to a low molecular weight heparin should that be needed. Hence, regular reassessment is very pertinent. Now we will talk mainly about the direct oral anticoagulant agent, which have had some more data in the recent times. So certainly we are all aware of the CLOT trial, the CATCH trials, which are the landmark clinical trials which have established low molecular weight heparin as standard of care for management of cancer-associated thrombosis. And this is because they did demonstrate that they reduce the risk of recurrent VT without significantly increasing major bleeding risks. The DOACs have shifted this since the publication of Hokusai VTE, and now we do have 4 studies. And for all the purposes of the thrombosis experts, we will talk about less about ADAM VTE, but focus more on the bigger randomized trials with Edoxaban versus Deltaparen, which is your Hokusai VTE. Then there is the SELECT-D, which looked at rivaroxaban versus Deltaparen, and recently published the Caravaggio study, which looked at Apixaban versus Deltaparen, all in the cancer patients with the VTE. Going over briefly and comparing Hokusai VTE in cancer and SELECT-D, because they were published closer to the time together. And Hokusai VTE was a phase 2 study looking at objectively confirmed acute VTE in cancer. They excluded patients with basal cell squamous cell. And interestingly, the primary outcome was a composite. And this is not very unusual for cardiology trials, but this is very unusual for our VTE trials, because we have never used the composite outcome, because it's always been either recurrent VTE, and safety primary outcome would be major bleeding. So this was the first study which had the composite outcome, both combining first recurrent VT and a major bleeding event. And the SELECT went with the traditional route of looking at recurrent VT and then looking at safety outcome with bleeding. But all of them looked at duration of treatment was 6 months and followed them for almost a year. So Hokusai VTE compared edoxaban and Deltaparen. Again, we are all aware that for the edoxaban, you do need a heparin leeway for 5 days. And that's what they did, gave in heparin for 5 days, and then they went on edoxaban 60 milligram. Of course, and then the other arm got Deltaparen, which is the established CLOT trial regimen, where you start them on 200 international unit and drop them to 150 units after 1 month. So they also had a arm for dose reduction for edoxaban. We could reduce the dose for 30 milligram daily if your patient had a creatinine clearance of 30 to 50 or a body weight of less than 60, or if they were receiving concomitant treatment with a potent P-glycoprotein inhibitor. This was the only trial that allowed that reduction based on these multiple factors. So overall, when you look at the patient population, they were all approximately 90% of them had a solid tumor malignancy. Metastatic was found in 60% of patients and 57% in Deltaparen and EDOX. Approximately 70% in each arm had received a cancer treatment in the 4 weeks prior to their enrollment. So that is just outlining what we just discussed, that they also had some representation with incidental VTE in both the arms. So when you look at the primary outcome, which is a composite, it demonstrated that edoxaban was non-inferior to Deltaparen with respect to the composite endpoint and that's what they had set to achieve, and they did. When you look at the individual endpoints, breaking down into recurrent VT and major bleeding, edoxaban had a non-significant reduction in VTE recurrence compared to a Deltaparen, but not the major offset was, of course, the major bleeding, which was higher with edoxaban compared to Deltaparen, mainly driven by the gastrointestinal unresected tumors. And then the clinically relevant non-major bleeding was also higher with edoxaban compared to Deltaparen. Similar kind of a story with SELECT-D, and this was again an open label multicenter randomized pilot trial comparing your rivaroxaban, and this was initiated similar to your VT regimen where you start them on the higher dose of 15 milligram twice a day for 3 weeks, and then they go on 20 milligrams once a day. They had 2 arms initially planned for SELECT-D, but they dropped the second arm after that and did a sample recalculation because of difficulty in recruitment. Again, primary outcome was recurrent VT over a 6-month follow-up period. Patients with basal cell and squamous cell cancers and ECOG performance status greater than 2 were not included. Greater than, again, 95% of patients in both arms had solid tumor malignancies. 58% of them had metastatic disease. Approximately 70% in each arm were receiving cancer treatment. So what are the results? So looking at the VT recurrence result, it showed statistically significant reduction in that primary outcome of recurrent VT at 6 months in the rivaroxaban arm compared with 4% to 11%. And the primary cancers that showed this greatest risk of VT recurrence were gastric, pancreas, lung lymphoma, gynae, and bladder tumors. But the major bleeding was a similar story, as we saw in edoxaban, was higher with rivaroxaban compared to Deltaparen, although not statistically significant. Clinically relevant non-major bleeding, however, was significantly higher in the rivaroxaban arm compared to the Deltaparen arm. But there were many shortcomings with this study that, of course, as we talked about, they didn't do the second randomization because it was not feasible. So that affected their sample size. And they did not specify central adjudication of suspected VT events. And after a safety analysis of first 220 patients, they saw that there was higher bleeding with GI, and they stopped enrolling these patients into the rest half of the study. So that definitely would have influenced their bleeding outcomes. So not perfect, but that's in the same theme as in edoxaban. ADAM-VT, very debated study because I'm not going to touch too much on it, but this was a smaller study where they were looking at Apixaban 10 milligram versus Deltaparen, and primary outcome was major bleeding, and they had just around 300 patients, included 257. Interesting study was the results were very shocking to thrombosis and especially cancer thrombosis docs, because they saw major bleeding occurred in 0% of patients who received Apixaban. This would have been a holy grail if that was true. But we do know that that is not the case. People had bleeding even on the placebo arms. So it's not very believable that they had 0% bleeding at all. And that raises concerns about patient selection within the study. Similar kind of a story with recurrent VTE, where they had even lower than the baseline VTE population that we see in cancer patients of 0.7% with Apix versus 6.3%. So take that with a grain of salt, but that's why we needed the Caravaggio study, which was a better designed, larger study, randomized over 1,170 cancer patients to receive Apixaban, compared them to Deltaparen, treated for 6 months. As with other studies with DOACs, again, patients with basal cell squamous cell ECOG status were worse than 2 were all excluded. Notable difference, however, with the exclusion of patients with primary brain tumors, known intracerebral mets, and acute leukemics. So you have to take that into consideration when you're extrapolating those data. So as with other studies, a good distribution of patients, about 68% of patients in each arm had recurrent, locally advanced or metastatic disease, and 60% in each arm were receiving concurrent cancer treatment. So these are the results for the Caravaggio study. It showed that Apixaban was non-inferior to Deltaparen with respect to recurrent VTE, with 5.6% versus 7.9%, and was primarily driven by low rates of recurrent pulmonary embolism, which is significant. As we know that PE is a more cause for death in these patients. What about the safety outcome? This was the difference between Caravaggio and the others, that the major GI, there were similar rates of major bleeding between Apixaban and Deltaparen. Even here, GI bleeding was most frequent type of major bleeding, but not significantly different. Major non-GI bleeding was 1.9% versus 2.2% between Apixa and Deltaparen. So overall, promising results, not that significant bleeding that was seen as in comparison to Edoxaban or Rivaroxaban. Caravaggio, what about the clinically relevant non-major bleeding? You have sensed a theme now, because that kind of was the same issue with Edoxaban, similar kind of an issue with Rivaroxaban, and a similar kind of an issue was seen with clinically relevant non-major bleeding was numerically increased with Apixaban compared to Deltaparen. So it was around 9% versus 6%. So, and this was mainly driven at this point with some in GI, but there was also the GU, and there was some upper airway bleeding as well. So now, since then, there has been some subgroup analysis that has been published looking specifically with bleeding with Apixaban. And we do know that the colorectal and lung were the major malignancies in these, and major bleeding occurred in overall 45 patients in Apixaban arm and 23 in Deltaparen. Major bleeding occurred in our 9 patients with GI cancer in each treatment group. But they did not find that the sites of major bleeding and their distribution was any different between the 2 treatment groups, and not a lot of the severe to fatal bleeding were only six patients in Apixa versus 5. Again, similar kind of a thing with the clinically relevant non-major bleeding event, numerically higher in Apixaban versus 35 in the Deltaparen group. So this was their breakdown, and I have gleaned this from their study, because this is important to know. Colorectal cancer certainly was similar kind of a bleeding risk, but when you look at it specifically, the bleeding happened in non-resected GI tumors rather than resected. So this would help us tailor those treatment options for these patients. That certainly maybe DOACs would be a better option in these patients with the resected tumors than the non-resected ones. Maybe you need to still be cautious. Compared to this, that's a highlight of that, was that no major bleeding events occurred in patients with resected upper GI or colorectal cancers. So what's the conclusion of Caravaggio? Oral Apixaban was non-inferior to Deltaparen. It may have a favorable bleeding profile. Episode of non-major bleeding was higher in Apixa group, similarly to what was seen in the other DOACs, with bleeding in the gastrourinary tract and upper airways driving that. Again, highlighting trial excluded patients with brain tumors, known cerebral mets, acute leukemia. You should exercise caution when extrapolating this data to these groups of patients. It's been highly debated in terms of, how adoptable this results would be, but it's kind of as a similar kind of a thing that we have seen with the Apixaban, and if this convinces patients of physicians of more comfort level with it. But remember, none of there is difference in the patient population in each of these clinical trials, which might have influenced it. And so results, so overall, when we without a head-to-head comparison of it, it's really I would caution anyone of selecting that without, in the absence of a head-to-head trial data, which we may not have, but that doesn't mean one is better than the other at this time, as far as we can tell. What about the concomitant anti-cancer agents? We did briefly touch upon. They also did another subgroup analysis of those specific patients who were treated with this concomitant anti-cancer agents and Apixaban for cancer thrombosis and compared those with Deltaparen. Overall, they did not find no significant differences in terms of those patients who were treated with the inducers of P-glycoprotein or CYP3A in terms of recurrent VT or major bleeding. But again, significant risk of a clinically relevant non-major bleeding occurred in Apixaban arm versus Deltaparen group, especially in those patients with lung and colorectal cancer treated with some pyrimidine analogs and monoclonal antibodies. But this was, again, a subgroup analysis. It has its drawbacks, just given that it's a subgroup analysis. So it's not powered enough to identify any potential increase in that risk of VTE and bleeding with different classes of anti-cancer agent. Remember, all the initial trials also excluded strong inducers and inhibitors of both CYP3A4 and PGP. And these patients generally had better liver function. They had better creatinine clearance. So this will affect your generalizability of any other cancer patients who may not fall into that category to extrapolate that data. So this is, again, I owe it to Dr. Cynthia Wu, but I love the side-by-side comparison of all the clinical trials, because it helps you understand what the patient population and what the inclusion criteria is, how would they have influenced. Because when you look at the CLOT trial, you already see that they are more sicker patients. They had more metastatic disease. There were more of them were on cancer chemo. ECOG status was also much higher, especially 2 and above. So you could argue that the CLOT trial had more sicker patients in comparison to the other studies in the DOAC patient population. We still need that into consideration. And low molecular weight heparin is definitely not out of the gate when it comes to cancer-associated thrombosis treatment. Moving on to this, having this knowledge, what does the guidelines tell us? There are many guidelines published in the recent years, and most of them have been updated, but not all of them have been updated since post-Caravaggio. But you have many referrals that you can look into. There's the NCCN Cancer Network. There is the ASCO guidelines. There is the Canadian guidelines, which is a treatment algorithm in cancer-associated thrombosis, developed by the national thrombosis experts, and the ITAC guidelines as well. Now, ASH has also come up with, that is the American Society of Hematology guidelines, and there has been some guidance documents from the scientific subcommittees of ISTH for thromboprophylaxis as well as cancer associated. Again, they all need to be done, and most of them were pre-Caravaggio, so there will be some updates coming through that. And overall, the guidelines do recommend any DOAC. Like, they do put DOAC in the front line for the initial treatment of it. And of course, the duration varies between certain guidelines, but at this point, minimum is 6 months of treatment for a cancer-associated thrombosis. This is the Canadian algorithm that I have talked about, which will give you some sort of an idea about how do we tailor it. And when you're dealing with a cancer-associated thrombosis, consider that risk of bleeding that we talked about, depending on what's your type of cancer. And now with the added information provided by the Caravaggio subgroups, then you will need to make a decision whether it's resected tumors versus unresected tumors, luminal tumors, and then again, reassess drug-drug interactions and then make a decision whether they're appropriate to go on low molecular weight heparin or are they appropriate candidates for DOAC. And remember again that the cancer journey will change and the risk will change. So you need to reassess them on a regular basis because they may go on a second line treatment. They may go on a clinical trial, which will change your drug-drug interaction equation and hence may need reassessment. But this will be updated in this year, and this would be happening pretty soon in the next few months. So overall, DOACs in CAT, definitely they are changing the landscape of cancer thrombosis treatment. But in the absence of head-to-head comparison, I would caution in concluding one DOAC is better than the other because there was significant patient heterogeneity within this trial. Careful patient selection will remain key, especially with upper GI cancers or unresected luminal tumors. Still limited data regarding the influence of these drug-drug interactions, especially with strong inducers or inhibitors of these newer cancer therapies such as checkpoint inhibitors. Low molecular weight heparin will remain relevant in these selective cases because remember, we still don't know what to do if they have a recurrent VT on a DOAC. All you have is switch them to a low molecular weight heparin. With the low molecular weight heparin and you have a recurrent VTE, we have dose escalations in place, but not the same with the direct oral anticoagulant agent. And of course, thrombocytopenia can occur during the cancer treatment in certain cancers more than the others, such as hematological malignancies, which may make it challenging with the direct oral anticoagulant agent therapies. And CNS cancers, we talked about how the primary CNS and some of the studies did exclude even intracerebral tumors. So be cautious about extrapolating data in these patients. And what about severe renal impairment? And in those kind of scenarios, your low molecular weight heparin would be the choice rather than a DOAC. So again, caution when extrapolating data to cancer patients who are excluded or underrepresented in your randomized trials, like your leukemics and bone marrow transplant patients are a whole other game. And also cancer-associated thrombosis or catheter-associated thrombosis. Areas with limited no data that still need further research. We talked briefly about the catheter-related thrombosis, upper extremity DVTs, because the evidence is quite scarce for that. They're small studies and they were not randomized clinical trials. So you need to, the evidence is, it needs to be more stronger. We need more trials. And what about in patients receiving specific targeted cancer therapies like anti-angiogenic monoclonal antibodies like bevacizumab, checkpoint inhibitors? And what about patients who have had upper GI tract surgical resections or they lack an appropriate upper GI tract and where there is an absorption is an issue, whether we would be confident enough to prescribe DOACs in these patients, or should we be sticking with low molecular weight heparin? There are certain new trials coming down in the pipeline. One is a Canvas trial, which aims at looking at more how can we choose the agent based on side effect, drug interaction, practical issues such as copays, and especially this might come into play in a socialized medicine environment like in Canada, where people may not have full coverage for the DOACs for the long duration of treatment for cancer-associated thrombosis. So this will be an interesting trial to look for, but this will be mainly enrolling out of the US. Then there is the MACA card. The reason why I brought this up is that because this also includes patients with cancer patients, and these are the ones who are on direct oral anticoagulants and for atrial fibrillation or VTE. The data with atrial fibrillation and patients on DOAC when they develop cancer, it still remains a bit unclear whether you would continue them on a DOAC or would they switch them to a low molecular weight heparin, right? Certainly we can say with confidence that if for a VTE management perspective, we have data with DOACs, but really that is lacking with atrial fibrillation patients and especially if they have cancer. So might be some interesting data to look for. APICAT is a study which, again, can we lower the dose of a DOAC at any point of time in these patients? So this will look at low dose regimen Apixaban, whether it is non-inferior to full dose regimen in all those patients who have completed that required period of 6 months. And this is going to be opening up soon in Calgary, and we will be recruiting from Calgary. We look forward to discussing those results down the road, because these may change how long we treat them for. So that's my presentation. I'll be happy to take more questions, and that's just my dog, which patiently wait every day outside my daughter's door until she wakes up. That's, yeah, she's an adorable boxer. So happy to take any questions.
Thanks, Deepa. That was a great review on a topic that we don't usually review. Let me ask you something. One of the things that I was kind of interested was that, most of these trials, if you compare them to the atrial fibrillation stroke prevention population, usually we hear about net clinical benefit.
Yep.
And the net clinical benefit here seems to be very marginal in some populations.
Yep.
Because the event rates seem to be low, and that may be related with the type of cancer, whether it's been resected or not.
Yep.
You showed the data on resection, not, but there were 5 patients here, 5
Yeah.
there.
Yeah.
So even though, food for thought, how do we put that together? Should some of these trials, in the Hokusai trial, the primary outcome is sort of a net clinical benefit, but not completely. So should we be looking at this in this population more?
No, I think so. I think so. That's been discussed as a, should we be actually looking at the net clinical? There has been some published in the previous trials, but not since the Apixaban. So I agree, that will be that will be more clinically relevant, right? When we're talking about net clinical benefit. I agree. The numbers are pretty small, right? That's the thing with subgroup analysis anyway. But it's a signal nevertheless, because I think clinical practice, we do see that sometimes, that people with unresected tumors do definitely have a bleed. If there's a bleeding big tumor in the GI tract, that's likely higher risk for bleeding. No, I agree with Carlos. I think we should definitely look at that.
So there's a question from
Mhm.
Dr. Brian Clark that asks if would the flow diagram also be the similar approach for anticoagulation and atrial fibrillation as well? Low molecular weight heparin for high risk GI, GU, and avoid DOACs?
That's going to change now, because Apixaban data was, did show that there was not that significant bleeding. So how we are going to tailor that into that algorithm is going to be something we will be discussing. And I'm on that algorithm committee that we will be updating soon. But I don't think there's been similar kind of an algorithm for atrial fibrillation, but I would assume it'll be the similar kind of factors to consider, maybe not the type of cancer, but at least the risk factors for bleeding, right? And the drug interactions, etc.
You think that Corona risk score needs to be updated with
Oh,
some
certainly.
some of these new
Yeah.
data that
Yeah.
you've shown? So like the
Mhm.
Corona Plus or something like that, because looks like, and also, maybe the decision in who you should anticoagulate and how should take into account that beautiful slide that you showed on the journey.
Yeah.
Maybe keep high doses when you're in the hospital,
Mhm.
but still, even when you're in remission, you have a threefold
Yep.
increased risk of that. So is there any
Mhm.
role maybe for a low dose aspirin, low dose DOAC, like the, Compass trial thing
Yep.
in cancer?
That's where the APICAT is going to help us, I think, because that's why I'm very excited to bring that to Calgary. I think it'll give us, get our patients that opportunity to enroll and see what that data looks like. Is there any point, right? That's where I find, that graph is so beautiful, because it depicts all that, the risks, that it's not going to be the same. So which point actually in that journey are we comfortable with dose reduction with the DOAC, right? So those are all interesting unanswered questions. So there's a lot more to do.
Well, thanks, Deepa. That was a fantastic review, and thank you for spending the time with us this morning. So have a great day, and hope we can collaborate with you in some of these
Yeah,
trials also.
definitely. Looking forward to the Freedom COVID, Carlos. That's going to be interesting too. Yeah.
Yes, let's hope we can get that started.
Yeah.
Okay. Well, you take care.
All right, guys. Thanks.
Bye.